Thank you very much for the nice introduction. I will talk a little bit more about strategy, how to improve the stroke therapy. Stroke, let's see, is a very complex disease and having a lot of different mechanisms, depending also in which stage, if it's like in the early stage, minutes, hours, days, or weeks. And now I'm talking about if you have occlusion in the blood vessel. And we know in the very early stage, in the minutes, we have a reduction in the cerebral blood flow that then leads to other damages. And within hours, we have vasoconstriction, we have upregulation of the G protein coupled receptors, inflammation, BBB disruption, metalloproteinases, apoptosis, edema, a lot of different mechanisms going on. And after some days up to weeks, we have a repair regeneration. And that's why we always talk about it's so important where we add our drug depending on which mechanism we want to inhibit. And today, as we talked about previously, we just have one drug that we are using in the clinic, and that is the TPA. But TPA has both beneficial and deleterious effect, because if you get it in the early stage within 4.5 hours, it's actually the clot that we have here gets opened up in the vessel, and then it's beneficial. We should also remember that this can just be used for the not for the subarachnoid hemorrhage strokes, so it's just for the 80% of the strokes that we are getting. And if we get it in a later phase, then we get more like a neural exitoxicity and damage, and we get the hemorrhage, we get the increase of the MMP9s, and so on. And even the patients that get the TPA within the time window of 4.5 hours, it's not all of them that react to it in a beneficial way. So in total, we just have 5 to 15% of all stroke patients worldwide that receive the TPA. And as yesterday we talked about, we have this dead tissue that we call the core, and this tissue here around that is called the penumbra or tissue at risk, or there is different definition of this tissue, but this is, however, the tissue that we can still save, that is not dead. And this is our target when we talk about treatment for stroke. So today we have actually more than 1,000 treatments that has been tried in clinical trials, but all actually failed in a major clinical trials. There have just been 3 treatments that actually did not fail, and they were all thrombolysis. So what we are talking about today is that the neuroprotection treatments, when it comes to the clinical trials, have not been successful so far. So what is the reason for this translational roadblock? There is several reasons for that. One is that the major focus so far has been on the cellular and molecular events of the neurons. And actually less attention has been devoted to the pathophysiology of the cerebral blood vessels. And here I come back to when you get a stroke, the first affected tissue is the blood vessel. There is where we get the clot, and then we get the neurons damage afterwards. But so far we have been looking a lot what's going on in the brain, what's going on in the neurons, but we forget what is the first point where we actually get the damage. And secondly, most therapies have focused only on one single destructive mechanism. As we also talked about yesterday, maybe a multiple drug treatment could be useful. And as I shown in the first image, we have so many different mechanisms going on. So just focusing on one single one will most likely not be beneficial. Third, the timing when we give the treatment has sometimes also been wrong, or actually even because we have to consider some drug, if you give it in the early stage, they can be beneficial, but if you give them in the late stage, they're actually detrimental. So the time is extremely important when we add our drug, depending on what kind of drug we are adding. And also what we just talked about in the previous talk, the animal models that we are using today is maybe not the one that actually represent the pathophysiology of natural occurring cerebral ischemia. Even my own group, we are using a lot of the MCA occlusion model, the focal ischemia. But is that the model that actually happening in the clinic? I mean, there is some clinicians here, and I will say you all will say no, because it's more like the thromboembolic stroke that's actually happened. So we should also consider that as one of the major factors. The drugs that we are testing, are we using them in the right model? First, the right model of stroke. Secondly, it's not a young male 20 years old guy that gets a stroke. And this is 95% of all our preclinical studies are done in rat male. So we should also consider that we have the age factor. Secondly, it's most of the time it's not healthy people that get a stroke. 50% have like hypertension and so on. So there's so many different risk factors. It's the right model of stroke. This should be age. What is the different female, male, hypertension, and so on. So once we really have a drug that we say, okay, this works, we should not just say, oh, it's the new drug. We have to go much further to test it in different situations before we go further on. And as we talked about previous, we have been focusing, either we focus on the neurons or we focus on the blood vessel, but we're actually forgetting it is a whole unit. I think we should put much more focus on the neurovascular unit on itself, because here we have the astrocyte, we have the neurons, we have everything, and what we can see, here is where we get the occlusion in the blood vessel, but everything is connected. We also yesterday talked about the microglia and so on, the astrocytes and neurons. And we have to actually look at the whole thing as one. And because if we take out just and look on this part or this part, we get some information, but it does not help us to answer the whole question, because maybe our drug works very good here, but not good here. And it's like, I think it's very important that we see the whole neurovascular unit. And mainly our group, or in the laboratory that I'm working, we are looking that actually stroke is primarily a vascular disease. That the focus that we are having in our group is that once a blood vessel gets clotted, and we think that if you cannot get the blood flow back in the then any neuroprotective drug will not have effect or very minimal effect. And what we have shown is that we have an upregulation of the endothelin receptors in the middle cerebral artery after thromboembolic stroke in humans. And several studies have shown that this endothelin, which is a vasoconstrictor, and this is taken out from patients that got a stroke. And we see we have an increase of the ETA receptor, and in similar we have an increase of the ETB receptors in the middle cerebral artery. And if you have a normal blood vessel, then you have the endothelium B receptor on the endothelial cell, and you have the ETA receptor on the smooth muscle cell. But after a stroke, you actually have constricting ETB receptor on the smooth muscle cells as well. In additional, we looked at more receptors, and we also looked at the angiotensin and the 5-hydroxytryptamine receptors in the humans. And we see that we have an upregulation of the angiotensin 1 receptor and the angiotensin 2 receptor and the 5-HT1B receptor, which is a serotonin receptor. And all this was seen in the MCA in the humans after thromboembolic stroke. And then we wanted to look in more closer, where is this upregulation happen? Is this really happening in the smooth muscle cells? And we can see that we have both here is the endothelin A receptors, and after the stroke, we have an increase in the smooth muscle cells, and similar we're seeing with the ETB and the angiotensin 1 and 5-HT1B receptors. So the conclusion is that we have an increase of this G protein coupled receptors that's a vasoconstrictive on the smooth muscle cell after stroke. So then we went further. What about the pro-inflammatory factors and MMPs after stroke? And here we also show that we have an increase. This is done after 24 hours after stroke. And we have an increase of the INOS, interleukin 6, TNF alpha, MMP9, interleukin 1B. This is nothing that is new. This is something that several groups have shown that this is happening. But our question was, we have so many different pathways involved in stroke. So if we want to inhibit something, where should we actually go? We know all this inflammation is upregulated, when activated. We know that we have so many vasoconstrictive receptors. We know it's going on in the smooth muscle cells. So what we wanted to do, we actually wanted to look more in closer which pathways are actually, because now we had the fact what's going on, but do we have a common pathway that we could actually block all these things? So we focused in here on the protein kinase C and the MAP kinase pathway, and with the STAT3 pathway to see what we have. And our hypothesis was, and also that we showed, is that, and we have been using 3 different models. We have been using the cerebral hemorrhage model, the focal ischemic stroke, the global ischemic stroke, and independent of which one of these strokes that you get, we show that you have an activation of the protein kinase C pathway, the MAP kinase pathway, the CMK2 pathway, and all this leads to a gene transcription, which leads to the upregulation of the G protein coupled receptors, the ETA, ETB, 5-HT1B, angiotensin, thromboxane, and all this leads to a vasoconstriction that leads to a worsened cerebral ischemia. In parallel, we have an increase of the MMP9s, which leads to the breakdown of the BBB. Oh, thank you. Which leads to the edema, inflammation, and also worsen the ischemia. So our whole idea is that if we block here somewhere, can we then inhibit all this and we have a better functional outcome? So we focused into this MAP kinase pathway as one step to just block here and see if we could, since we know that this leads to the reduced, because we think it's the reduction in the cerebral blood flow that is actually then causing all the different things. And by using a specific, we use a lot of different kind of MEK ERK1/2 inhibitors in the different models. And the one that we found out to be the best one was the U126. And if we were using that, we could see that we get a less injury because we have a smaller infarct and we have a better functional outcome, which I will show you here. So by using this U126 at different time points after the stroke, we could reduce the infarct volume. And this was done at 0 hour after stroke, 6 hour after stroke, and when we gave it 12 hour after stroke, we did not have an effect. So we have a time window here up to 6 hours, but not more. So we have been extending it a little further compared to the TPA. And the advantage is also we can use it. We don't need to know if there's a bleeding or not, because this drug also worked in the cerebral hemorrhage model. And we could show both in the global ischemia, in the focal ischemia model, that we have a better functional outcome. And here, this is the one without drug, and this is the vehicle, and this is the sham. And we see we have a much improvement in the behavior, and this was measured up to 7 days after a stroke. And similar was seen in the focal ischemia model, that here we have an improvement in the functional outcome, which was measured up to 14 days. And then we went further to see how was it in the subarachnoid hemorrhage model. And even in the subarachnoid hemorrhage model, we can see this is our treatment group, and here we have the subarachnoid hemorrhage group, and this is the vehicle group, and this is the sham group. So we see we have an improvement of the functional outcome even in the subarachnoid hemorrhage model. And then we went further on and looked at the cerebral blood flow with the autoradiographic method to see were we also able to prevent a reduction in cerebral blood flow. And here we see after subarachnoid hemorrhage, we get a significant reduction in the cerebral blood flow, which we are able to prevent with giving a MEK inhibitor both at the 0 hour and after 6 hours. And then we have looked, as we said, on the vasoconstriction, because as I told before, here I'm just giving an example of the ET1, but we have been seeing similar kind of effects for the 5-hydroxytryptamine, for the angiotensin, from the thromboxane, and the same thing has been observed in all these different models of stroke. And this is done in the middle cerebral artery. And here we have the concentration of the ET1. On here we have the contraction in percentage. And what we see after the, here we have the, now I see, here we have the stroke, and the vehicle. Here we have the black one is the sham group. And when we give the treatment, we can see that we can actually inhibit this increase in contraction. And similar results are seen with the subarachnoid hemorrhage model. Here we have the vasoconstriction, and when we give the drug, we get a decrease here in the vasoconstriction. So we have seen that we have a less vasoconstriction after giving our MEK inhibitor. So then we went in to really confirm, is it actually on the smooth muscle cells that we are inhibiting these receptors upregulation. So here we have the 5-HT1B, the angiotensin 1, and the ETB receptors. And here we have the smooth muscle cells, and we also had some brain tissue because we cut out the MCA and a piece of the brain in that territorium to actually confirm, do we have the upregulation just on the smooth muscle cells, or do we also see that on the brain tissue or not? And what we could see is that we actually have them, because here you see there is the brain tissue here, and there we have no upregulation of the receptors. So it's actually, it is on the smooth muscle cells we see these receptors. And after giving our treatment, we are able to reduce this upregulation of receptors. And this has also been confirmed by Western blot. Of course, with the Western blot, we don't know the impact the endothelium have because we have taken the whole vessel and we have not been able to separate the smooth muscle cells. So actually we use the immuno to confirm the localization. And here is just to confirm that it is actually the phosphor-ERK pathway that we are blocking. And we see here in the smooth muscle cell, we have an activation with the phosphor-ERK 1,2 that is blocked. And we have done both the mRNA, the Western blot for this as well to confirm that it's really the protein levels in a more quantitative method. And what about, does this pathway also, because as I showed before, we have an increase of the pro-inflammatory mediators after the stroke. So we have been able now to show, okay, is this a common pathway that we can actually, we have an improvement in the functional outcome, we have a less infarct size, and we have been able to inhibit the vasoconstrictor receptors. But what about the inflammation? And here we are showing the INAS, interleukin-6, IL-1 beta, and TNF alpha. So here is the control group, and here is the MCA occlusion. And we see we have an activation in all this part. And here we also have an activation. This is the smooth muscle cell. Because our focus has been all the time on the blood vessel. But we also see here that we have, as well known in some of the brain tissue, the inflammation is activated. And by using our inhibitor, the U126, we're actually able to block these pro-inflammatory mediators. And then we went further to actually look what about the MMP9s, because we think they're very important in the BBB, and we also think that they are also, in general in stroke, it has been a very important factor. And this is done in this data is shown from the cerebral hemorrhage model. This is shown at the 2 days after cerebral hemorrhage, we have an increase, which we're able to prevent with the drug, and similar results are seen after 3 days after cerebral hemorrhage. So if we go back for the cerebral hemorrhage patients, there has been clinical trials with a clazosentan for cerebral hemorrhage patient. And the drug, it reduced the vasospasm because this is one of the major targets when we talk about the cerebral hemorrhage. But all these clinical trials that was done, it was actually failing to improve outcome. And the question that was asked, how can it actually reduce the vasospasm, but we don't have a better outcome? And I'm not a clinician myself, but I think all the clinicians here, they don't care about what drug is given and what effect the drug has and what mechanism it has, as long as it's improved the outcome of the patient. And I think that should be our main target, because even if it's inhibiting mechanisms that are upregulated, activated, if you don't have an improvement in the functional outcome, we should put down our work and try something else. And why some of that is because we see that the clazosentan is actually blocking the ETA and E2B receptors. And we have seen that that is upregulated after cerebral hemorrhage, and that has been shown in patients and in several studies. But we have to think why. One of the reasons why it maybe did not work in the clinical trial is that we don't have upregulation of one receptor. We have actually elevated expression of several contractile receptors. So just by blocking one of this is not sufficient. So what we actually did, we took the clazosentan that was used in the clinical trials and compared that with our U126 to see how is the functional outcome in the rats for that. And we did several behavioral tests, because we think it's always important to do more than one behavioral test, because we have to consider different tests are for testing different parts. And what we can see here, that with using the clazosentan, which is the blue one, here we have the same, we don't have any improvement of the functional outcome in the rats. But with using the U126, we're actually getting closer to the sham after day 3. it takes some time for them to, and similar are seen here. And then we went back, so we're actually going from the clinical and taking the clinical problem and trying to answer that preclinical to then be able to take it back to the clinic again. So we think one of the reasons why this clinical trial did not work is that we tried to just block one thing, and we think that the animal studies had not done good enough to actually, because if this would have been done, we will never have taken it to the clinical trials before. So in conclusion, our hypothesis is that we have, when a stroke happens, independent of which kind of stroke happened, we have an activation of all these pathways which lead to a gene transcription. This is going on the smooth muscle cell. And we have an upregulation of the gene protein coupled receptor, but we have an upregulation of several receptors. So it's not just one. And this leads to vasoconstriction. But in parallel, we also have the breakdown of the BBB, we have inflammation, and what we have been able to show is actually if we block one of this pathway, we are improving the functional outcome. So what is the future perspectives? We will say actually to identify additional vascular signaling molecules that could be as a novel therapeutic target. Because we have been looking at a lot of different ones, but I think there is even better ones that could be, because now we have shown all this in the preclinical, but before moving to the clinical, we probably would do a bigger screening once again, because it also needs to be tested in additional animal models. Here we have showed it in 3 different stroke models, but I think here we have to go again to a more what's going on in a thromboembolic stroke model and so on. And again, the risk factors, because I don't think we can take a drug into the clinical trials until we have tested it more widely in the preclinical. What happens in the sex, the gender? We know that male and females react differently. Is it promenopausal or after? I think it's very important that we test it in both genders. And we also have aged animals, because how does this drug work in the aged animals? A risk factor is hypertension. We have started some of those studies already. And then smoking and so on, diabetes. I think it's very important once we have found something that we actually take it further before we even consider to take it into the clinical trials. And of course, as a one-group lab, doing everything on your own can be very difficult. And there I think collaboration is a very good start, because we have different focus. But if we have something that is really showing promising, it's important that we try it out before we go further. And I think this has been one of the lack in the past. And I would like to thank all the members from my group, of course, and especially my PhD students that have performed a lot of work, and also the Professor Edvinsson that has been supporting all this work and being a part of it, and the fundings. And then I also would like to thank the collaborators, because right now we are developing to use more the MRI, since this is a very quick tool. And here we have a collaboration with Dr. Wetterling from the Trinity College, and also the new Department of Bioimaging Center at Lund, because we know in the animal models it's not that easy to perform the MR. You need a special coil and so on, but we can get a lot of information. And then we also collaborate with Dr. Orset and Professor Vivian from the Cannes University of France, in France, because they are mainly working on the thromboembolic model to test that in. Thank you for the attention. Questions?
So first of all, congratulations for your excellent talk. I am a little bit involved in ischemia reperfusion phenomena for years, from endothelial, side. So I learned something from you. Thank you very much. And you have on one of your slides very important question. It's very exciting for me. Why the drug reduced vasospasm by fail to improve outcome is unclear. You know what I would like to mention? You mentioned vasoconstriction, you mentioned inflammatory, but you did not mention vasodilatation. There are mechanisms who are responsible for vasodilatation. You know what I mean?
Yes.
The nature is very smart. We have molecules for vasoconstriction, and of course we have molecules for vasodilatation. So I am surprised, as I said yesterday, people are getting Nobel Prize for nitric oxide, for endothelial, neuronal, NOS, okay? And we are working, on some models and forgetting the whole story, So it will be interesting in your model to watch, what's happened with vasodilatation, all those, stuff responsible for vasodilatation, okay?
I will respond to that. I think it's also a very important factor, because the question is, do we have more vasoconstriction, or is it actually that we have less vasodilatation, and what is the parameters we have shown? And we have been looking a little bit on the vasodilatation as well. I did not show any data here. And in a lot of the models also, after the stroke, we have actually a dysfunction of the endothelium. So I will agree with you that this is an important factor.
Thank you for a very nice presentation. I have several questions.
Introduce yourself.
Yes. Svetlana Demyanets from Medical University of Vienna, group of Professor Hook. My first question is also somehow related to the question of Professor Hook, but to another factors. You nicely showed that pro-inflammatory mediators are involved in this context. Did you look on anti-inflammatory cytokines, for example, IL-10, also like another side of the story, but for inflammatory?
Yeah, no, we did not do that. The whole thing that we wanted to know is that we have so many. Of course, I think you could use a drug that was hitting the inflammation, but what we were trying to actually see is that we have so many different factors. Can we find a common pathway that will actually block all these factors?
Just to maintain this balance because of pro-inflammatory and anti-inflammatory, same like
I think
and vasoconstriction.
If you want to go further, I will probably suggest to use a combination treatment, because if you remember my first slide, there's so many different, and then it's maybe you want to have something that is inhibiting in the early phase, but something that you can actually give after day 2 or 3 to actually keep the levels down.
In my second question, your research is focused on cerebral arteries. And if you look, do you know if cerebrovascular smooth muscle cells differ from smooth muscle cells, or differ in receptor expression profile or other properties from smooth muscle cells derived from other anatomical location, for example, from coronary arteries?
We have been looking at that as well. Okay. And now I picked out a stroke, but we have seen actually, because what we want to do is, do we have a common pathway for the ischemia? This is the main topic, and we have been seeing that even after in the coronary arteries we have upregulation of the same receptors, and also now we are looking in the eyes, and there we also have an upregulation of these receptors. So we think it's not just in the brain, and we also looked a little bit on the mesenteric, and there we also have that after ischemia.
It would be important if you apply the system systemically.
Yes.
Okay, thank you.
You're welcome.
Aleksandra Piechota-Polańczyk, also from Medical University of Vienna. I have also a question about this endothelin, because you showed us a great figure on this. The level of endothelin 1 is actually decreasing, yes, after this drug that you used. Am I right? And what about the other endothelins? Because endothelin 3 is more important especially in the cerebral. Did you measure it also?
We did that in one of the models, not in all of them. We did that in the subarachnoid hemorrhage, and we see that it's also decreased. But
Okay.
yeah.
So thank you.
Thank you.
I just wanted to know, you looked at the endothelium. One of the things, have you looked at angiogenesis? The VEGF and things that do they have expressed in this your drug? How does it? Because
This
it
is
very
actually an
important.
ongoing work of one of my PhD students right now,
Right.
because most of the data that I showed has still been done in the short time. The later data is now extending, and yesterday I showed some data for the TA2, that we have an activation of the TA2 and the nestin. This is unpublished data yet. But this is a part of, because now we have shown in the acute phase, but what is actually going on the long term.
Yeah, thank you.
Welcome.
To addition, VEGF at hypoxia-induced factor too, especially here in this system.
Yes, it's depending on which time point you choose to look at. Yeah.
Nice presentation. In one of your slides, you have shown that there is an increase of INOS in 24 hours. For how much time, how much days it is being increased, and for after how much days it is being decreased then?
We did just do a time study up to 72 hours. So after that, I don't know actually what's going on in our models. But we see that it's IL-6 that you asked for.
No. INOS, inducible NOS.
Okay. Yeah, I mean, we haven't looked at it long. INS, which was looked up to 48 hours. So we know it's up at that time, and it's starting to increase after 3 to 6 hours after the stroke. But I don't know what's going on after 48 hours.
And is there any relation between the superoxides production at the level of synapse with this INOS? Have you got any idea for that one?
I don't know, actually. I mean, I suppose there is, but nothing that we have been looking into.
Okay.